So my name is Natalie Shoemate, and this is my final presentation over course objectives for NU664. The first objective for integrating nursing and related theories as it applies to pediatric nursing practice, and for adaptation and therapeutic interventions with families in the primary care setting. For this, I think about NAP and the AAP. NAP supports the improvement of the quality of life for our little patients through funding for education, and that would be for us. Continued research, clinical projects, and initiatives. Between the laws and NAP and the AAP, we are able to work with families in addressing, improving, and ensuring the health of the child, which is our ultimate goal. And then the AAP is, of course, a professional organization of pediatricians who are committed to the optimal physical, mental, and social health and well-being of all infants, children, and adolescents and young adults. As PMPs, we're going to follow the policies and guidelines set forth by the AAP, and we're going to do that every day for our little patients. Part of the AAP policy, which I see every day in clinical, is to have an effective patient-provider relationship. This is being positive, supportive, and loving the patients and families and meeting their needs where they are. We are here to meet their healthcare needs and support them in raising their children. And this begins with the first newborn visit or a prenatal visit. And our care should be developmentally appropriate for the child and also specialize according to the family dynamics, which we learn very quickly are very different. Other concepts that come to mind is that well visits are not just about the shots. It's about meeting the needs of the child. It's based on being able to assess developmental milestones, physical and cognitive abilities. And the well visits are designed to coincide with important developmental milestones in the life of the child. Health history is important, assessment's important, and screenings are so very important for these visits. Oftentimes we find a lot of interesting stuff in these well visits, so I'm seeing in clinical. And according to the National Survey of Children's Health, there are many children at moderate to high risk for developmental, behavioral, and social delays. And these well visits are where we can find these and help them get the assistance they need to hopefully have a better quality of life. And the sooner the assistance, the better. One example would be the parent self-reporting screening of their child, which the AAP recommends at 9, 18, and 24-month visits, which together with our observation and the physical assessment of the child, we can discuss meeting milestones or if they're not. And sometimes it's just a perception by the parents that they're not, and we can ease their mind through the literature and our assessment. Number 2, utilize research findings, adaptation and related theories, and critical thinking skills and planning the care for individuals and families. So I feel like this is knowing when to refer the patient to a specialist, when to manage the care ourselves, and when they need an acute or higher level of care. According to if we're following the standards of care for the AAP and Bright Futures, well visits, anticipatory guidance, vaccines, education, our supportive families is all based on the most up-to-date information. And we are responsible for staying up to date with that information. Some of the resources that I think of that are available to help with social determinants of health would be DFACS, WIC, Babies Can't Wait, and other programs through the local health department and churches, and the health department itself is a resource. Number 3, enhance effective therapeutic communication skills as a pediatric nurse practitioner with individuals, families, and members of the healthcare team to promote optimal wellness and adaptation. I think this deals with communicating despite language barriers. This is knowing when to use an interpreter, because if caregivers, they can't follow the plan of care if they don't know what we're even saying or what it actually means. And being cautious of using a family member and not an official interpreter. Being aware of educational differences or decreased cognitive abilities, we must first assess literacy in our patients. And I've seen this for sure. For example, if a mother cannot read, then how will she read the instructions on the formula can to correctly mix her baby's milk? We just can't take literacy for granted. People can't follow directions that they can't read. Communication in the office among nurses or the medical assistants for procedures such as labs, swabs, other procedures. Cultural consideration of the child and family. This can especially be important in giving medicine and also the diet of the child, because they don't believe in the medicine and they don't believe in the diet, or it goes against their culture. They're not gonna do it. So we got to meet them where they are. Develop decision making and clinical management skills using evidence-based concept as a pediatric nurse practitioner. So I feel like this is knowing when and how to refer to specialists. Optho, for example, if we have to refer for an IND of a STI that's not going away with our management, or periorbital cellulitis with vision changes, or a child less than 1, or if they're not being managed appropriately, not having an appropriate response outpatient. Such things for ENT like newborn, universal newborn hearing screenings, and pure tone odometry. This is supposed to be done at 36, 8, 10, 12, 15, and 18 years. Knowing that we refer to ENT if they've had acute otitis media 3 times in 6 months or 4 times in a year, with 1 episode being in the last 6 months. I've heard my preceptor tell so many parents this because they're very pushy about getting to the ENT sometimes for TNA surgeries or ear tubes. And I know as a parent that must be frustrating, but we should be following the AAP guidelines on this. Let's see, gastro, hematology, urology, cardiology, rheumatology, lactation, dietitians. Those are things that come to mind when I think about specialties and referral. In clinical, my preceptor just says, when in doubt, get them checked out. She doesn't refer for everything, obviously, but when it's best for the patient or something that she can't manage, then she refers. There's no need in ordering an x-ray on a kid with a broken leg if there's nothing you can do about it. Integrate ethical, legal, and professional standards of practice from the perspective of a pediatric nurse practitioner. So we have an obligation to report suspected child abuse and neglect. Also, right to privacy, confidentiality, the right to know, not know, the duty to warn, disclosure of incidental findings, genetic discrimination. These are among some ethical issues in burns and that we'll face as PNPs. We are legally obligated to talk about safe sex practices in the middle to older adolescent, but we can discuss privately with the parent how they, want to handle this. Evaluate personal needs for continued learning and professional development. To me, this means keeping up to date with the latest AAP guidelines, keeping up with the new literature and research, attending conferences, medication recalls, renewing certifications, and obtaining our PNP license and then renewing. Evaluate issues within the healthcare delivery system that affect the role of the pediatric nurse practitioner in delivery of care in the primary setting. So knowing about insurance coverage, ability to prescribe based on coverage and costs. And I think this comes with practice. I've seen my preceptor order stuff and say, these are probably not going to be covered. This is what pharmacy is probably going to offer, and I'm okay with that, or I'm not okay with that. Access to affordable, convenient, available care. I mean, there's not enough NPs in practice in the primary care setting, and medical care is so different than NP care. I feel like medical care is throwing a prescription at a symptom, and that's really not what we're doing as nurse practitioners. It's more holistic to me and functional. When you see chronic suppurative otitis media, perforation of the eardrum with drainage from the middle ear, the burn says, and also in Starther and Sato, that you might see this a lot in a lack of access to medical care, so they're not diagnosed timely with acute otitis media. issues such as poverty, transportation, foster care, lack of parenting, caregiver role at home, and we have to be aware of this as providers. In my state, in Georgia, we have limited ability to prescribe. So, like, we have a DEA number, but we still cannot prescribe all classes of drugs, and I've not kept that straight yet. And hopefully, it's going to change, and Georgia will get up to speed with the rest of the country. Promotion of lifelong health for families and communities. Um, so for children's health, there's social determinants of health. Health is determined by homes, schools, workplace, neighborhoods, and communities, and we must understand that it just not in our office. Um, we just need to support children to stay active, eat well, no smoking, get recommended immunizations and screening tests, see a doctor when sick. This is all part of influencing our overall health for the good, hopefully. Um, some Americans do not have the same quality and availability of care, and this explains why some are healthier than others. Health equality is attaining the highest level of health for all people. Of course, disparities are differences in health, and this is based on social, economic, environmental disadvantages, which can negatively affect groups of people, whether it's age, gender, mental health status, disability, or race. Integrate the role of health educator into clinical practice as a PMP. So we're educating patients and parents with every single visit. Sick or well, nurse visit for vaccine, lab draws, they're coming in the office, they might be getting educated. We are constantly educating office staff as well, keeping them up to date. Um, we've been helping in the office where I'm doing clinicals, like obtaining accurate measurements and weights. And if you've got a screaming 1-year old, knowing that you can put mom and baby on a scale and then take baby off and do the difference instead of making a toddler try to stand on a scale. Just little things like that, to make sure that we're accurately assessing the vital signs and measurements of our patients. Also, we did a little education on vaccine administration and needle size and length selection, and why, because you can't use a huge gauge long needle for a brand new baby. And you don't have the educational background, you just don't know that, you just do tasks. So that's our job, to continuously be educating everyone, I feel like. Um, so I feel like overall that I met the course objectives. However, I feel like I have so much to learn and so much knowledge to expand upon, and I will do this in 665, and it'll continue once we're in practice. I mean, you never stop learning in healthcare. I've enjoyed this semester. I appreciate my classmates, and Professor Monero. And I know that when we're done with this program, we got to take boards after we graduate, and we got to find a job. And I hope that we all find a job that we love and we can make a difference as nurse practitioners for our little tiny pediatric patients.